Hello, good afternoon. Welcome back. This session is called ECLS, and we are delighted to have some very prominent speakers in this session. I'm chairing this session with my delightful colleague, Maha, who works at Toronto, but originally from Oman, as I believe. First speaker, we have Prof. John Fraser, who I think most of us read a paper or two for him. He's a professor at the University of Queensland and a clinician at Prince Charles Hospital. He's the past president of Asia Pacific ELSO and the director of Critical Care Research Group with over 700 papers, I believe. His greatest achievement, in my eyes, is having 5 kids and surviving sometime in South London. So welcome, John Fraser, and we're all eager to hear about pulsatile flow and VA ECMO.
Lovely, thank you very much. I was being dared before whether it would be easier to do it in a London accent or a Glaswegian accent, so I'm happy to have a show of hands when we do questions. We'll do the second part of the talk in a London accent. So it's wonderful to be at such an international meeting, and I think internationality is the key to research, to changing outcomes, because our patients come from all nations, as do our research group here in Brisbane, which I'm always happy to invite Kuwait to too, because the more international we get, the better our research becomes over our engineering lab, our biology lab, our animal lab, and our clinical process. What we're going to talk about today, however, is pulsatility in ECMO, and I've changed my talk a little bit for some interesting work. We've been working in pulsatile VA ECMO for some time. I'm going to go through these data, but I'm going to propose to you a brand new idea of pulsatile VV ECMO. So we all understand the pulsatility of the left ventricle, but the right ventricle sometimes doesn't get the attention it's due, and the pulsatility of the right ventricle and the effect of shear stress in the pulmonary vasculature, because the pulmonary vasculature isn't just there to allow oxygen transfer, it's got so many other purposes, and that I believe is changed by the shear stress of VV ECMO. So ECMO's use has increased dramatically. We've seen graphs of this time, up to a 20% of increase, 20-fold increase in the use of ECMO, despite realistically not much data to back it. Cardiogenic shock, the outcomes other than a danger study, there's no improvement outcome. VV ECMO, the Eolia, the best clinical study, didn't quite get to p-values of 0.07. There's lots of ways of reassessing the data with Bayesian, etc. But the study protocol ab initio was looking for a p of 0.05. So we've got a technology that's increasing, but realistically, the data doesn't back it up, and it's an expensive technology. It's got risk technology. It can be harmful if used in the wrong patient population. So we have to look at the data, and this is one of the more recent studies, including all the major studies in the VA ECMO and cardiogenic shock. And the meta-analysis says in myocardial infarction-related ECMO, we haven't changed the outcome. The complications from this technology are such that, yes, we see people having a better pulse, perhaps a better urine output and better blood pressure, but they're not actually improving outcome. So we have to look at why this has changed. And again, 50 years ago, our understanding of cardiogenic shock was based on a very reasonable paradigm of the heart becomes dysfunctional, the pressure goes down, the oxygen is reduced, the organs become dysfunctional. And that was really it. But we understand more and more, and those that see lots of patients with cardiogenic shock, that there's an inflammatory component. And this has been pretty much ignored until the last 5 or 6 years, so that when you are in this shock state and the tissue is releasing bad humors and cytokines and toxic metabolites, there's an inflammatory excess that worsens the outcomes and worsens the flow across the microvasculature. And it's this inflammation that happens in sepsis, because there's sterile inflammation and non-sterile inflammation. And this inflammation activates your immune system, activates your white cells, and inflammation and coagulation are very, very strongly adherent or co-evolved, really, and have just separated since. So when we see the inflammatory excess, we see the nitric oxide dropping in the microcirculation. This narrows the microvasculature, which is where the oxygen is transferred to the organs, and you start seeing microvascular occlusion and thrombosis, and it's at this point that the microvasculature starts to collapse, because this is the point where the oxygen is given to the mitochondria. Now, what we do clinically is we measure the macrocirculation, because it's easy, we can do it, blood pressure, a pulse, a CVP, and when you're healthy, that's fine. But when you're unhealthy and you're sick and you're in an intensive care, the macro and the microcirculation uncouple. That is, they don't correlate. And our problem is, clinically, we don't have many tools to evaluate the microcirculation. There are some tools. They're mostly research kind of based tools. We'll just see if the video works here. This is some technology we use in our lab, and I'm not saying we should be using it clinically because it's really fiddly. But basically, it's SDF camera. You can actually not just look at the red cells, but you can actually track the red cells. So you can put what's called particle velocimetry programming and say, how many of these capillaries are open? How quickly are the blood cells going through? And how much oxygen is each piece of tissue getting? So our colleagues in Paris at Le Pitié did a study on standard VA ECMO, looking at the survivors and non-survivors based on their small vessel density, their capillaries, and the perfusion of those capillaries. So there was no different intervention, but they looked at survival based on the microcirculation. And what they showed was that those who recruited their microcirculation, and you need to get in early to do it, had a better outcome. And it directly related to mortality, and you had to do it soon. So not too surprising that if we want to get in, we get in quickly. We don't leave them for 4 or 5 days, because then it's non-resuscitatable. But it's the microcirculation is a key component. So our thinking is, why were we born with a pulse? There's probably a benefit from the pulse. And we've seen patients with LVAD survive and total artificial heart survive without a pulse, but we understand that there's a whole pile of different activities. The shear stress has changed, the activation of red cells has changed, the energy transfer at the level has changed, and the inflammatory excess has changed. But the pulse determines all of these things. So I would say to you that the ECMO you were using just now is currently unphysiological, and it doesn't answer what the microcirculation, the largest organ in our body, actually requires. So we have to go back, not just to medicine, but to literature, where Shakespeare said, to be or not to be. We would suggest to pulse or not to pulse. That is the question. And I'm going to present work that I'm a professor, so I don't do my own work. I give other people the work, and then I steal their slides. So this is Silver from Estonia, Andrew from Australia, Samia from Somalia and Finland, and Diane, an engineer, who's worked in these data. So the question is, what does the pulse need to be? So there are pulses and there are pulses. It's the dose of the pulse. So you can have a tiny magnitude pulse, like you see in an LVAD and some VA ECMO, or you can have a larger one. But the key that we're realizing, and this is what Dianans did in his PhD in our mock loop, you can get a pulse at the oxygenator, that doesn't matter. You can get a pulse at the cannula site, that doesn't matter. You can get a pulse at the post-cannula, but it's all about getting the pulse into the blood, because that's the energy transfer, and that's the signal that transduces to the microcirculation. This is all built on a mock circulation look. I'll talk about it later on, but essentially what we found was the bigger the cannula, the better, and the bigger the pulse amplitude, the better from this point of view. So we moved from an engineering lab with Dianan's work into the animal lab with Silver's work, and a large number of names that you'll see from all across our international collaborative. We looked at what animal models could we look at. So we looked at what was there before, and we said, okay, we don't really have a good, reproducible, clinically relevant model of cardiogenic shock. So we then started to create one. We did this with Roberto Lorusso, our good friend from Maastricht, and others, and we used alcohol injecting into the left ventricle. And we looked at the SHOCK 2 study, and we produced an ejection fraction of 18 to 23%. And this is such a nice model, you can actually titrate it to that degree. And the way that we did it, we'll just see if the videos work. Left thoracotomy, and we can just titrate the dose of alcohol under echo guidance to create an EF of 18 to 23%. This is what the ventricle in this sheep looks like beforehand, and this is what it looks like afterwards. So we've got a nice, reproducible, and we got 100% survival once we get the hang of it. We published this in the Blue Journal. I won't go on too much about it, but the key findings in this was, so all the animals had cardiogenic shock. Some had continuous VA ECMO that you would be using today, and some had our new device, pulsatile VA ECMO, using a device by Xenios. We don't have any financial association with them, and they weren't involved in the study. But pulse versus non-pulse, what we saw was peripheral vascular density, the number of capillaries that were open, improved when you gave the animal with cardiogenic shock a pulse, and there were more of them and more red cells going through that. So that's fine, but you say, well, does that actually make a difference? Well, it does. We then look at the respiratory burst chain of the mitochondria. So we can get the capillaries open, but does the mitochondria get to use that oxygen? And it seems it's the case. If you have pulsatility in the kidney, you produce more ATP. And if you've got pulsatility, you get less reactive oxygen, less of the negative inflammatory proteins. So these are two aspects that work. Our next aspect we know in VA ECMO, how do we get that LVEDP down? How do we reduce the LV distension? And there are some data suggesting that with this pulsatility, as with the balloon pump, we can actually reduce the LVEDP and pulsatility. Because I think LV unloading is a key, and the danger shock trial looked at this. There was an improved outcome, the first for mechanical support in cardiogenic shock, and there was an improved outcome. And there are data, and this is from the Prague group, Peter's group, looking at the pulsatility and the unloading of the LV, and also the improvement on the coronary blood flow when you look at pulsatile in the blue bar here. So this is a potential benefit. And the work that we're doing again in the lab with Dynanth, our postdoc, tells us that there's two aspects of the pulse. Those of you that are old enough to remember the balloon pumps that you had to move the buttons back and forward, it's going to be tricky with this too till we get to clinic. So we can reduce the workload of the left ventricle and improve the opening, or we can improve the hemodynamic energy transfer. They don't happen at the same time though. So we need to get across this to work out. We've got to balance the unloading of the left ventricle, which is important, but also optimize the microcirculation. So a little bit like the pulse oximeter, will be a crossover period that we do this. Again, we're not there yet. This is why we're still in the lab. When the sheep is relatively well and the pulse is below about 140, the device that we're using currently keeps up with the pulse and works well with the pulse. But when they become really tachycardic, when they're in really bad shock, it doesn't cope quite so well. So we're working on this with our engineers at the moment. In terms of coagulopathy, we know that von Willebrand factor is a macromer, and it's dependent on pulse, so our coagulation factors are actually dependent. The macromer, when we have it in our normal human, is like an accordion. It's a Scottish instrument. I'm not sure if there's a Q80 equivalent. So it springs out and comes back, springs out and comes back. But with a non-pulsatile device, it comes out and is elongated and doesn't work. So you want high molecular weight von Willebrand factor, and this is what happens with the pulsatility, because the pulse allows the von Willebrand to come back in. So therefore, your von Willebrand essentially is stickier and you bleed less. And this is what we've shown with pulse versus non-pulse. Interesting other things, we went back through the literature to see why was this so important. And we actually found out, and this is not our paper, this is from the 2009 group. If you look at mitochondrial function in the lab, they like shear stress. So the mitochondria has evolved to work better with shear stress, and their membrane potential is better if it has a pulse. And again, this is quite fascinating data. One of the first papers was 1969. So we talked about inflammation, and I'll speed through this. We know that there's the inflammation of the illness of cardiogenic shock, but there's also the inflammation of a device that takes 2, 3, 4 liters out of your body, a naked, non-endothelialized plastic membrane, and it causes its own inflammation. And we know that VA ECMO is associated with increased inflammation, but if you put a pulse across it, you get anti-inflammatory proteins and reduced inflammatory proteins. We know that endothelial markers are damaged substantially by VA ECMO, and if you have endothelial damage, your mortality is higher. And what we and others have shown is pulsatile flow is associated with reduced endothelial damage. So we've finished doing the first lot of animal work, and what we've shown is pulsatile ECMO versus non-pulsatile ECMO in cardiogenic shock. It reduces your inotrope requirement, reduces your endothelial damage, improves your mitochondrial function, and improves your microcirculation, which is fascinating. But when I was taught ECMO by Vin Pellegrino, as everyone was in Australia, I was surprised that H1N1, when their lungs were quite black at the top and white at the bottom, and then as soon as you put them in ECMO, it would all go white. And no one, including Vin, could answer me why that was the case. So having seen these data, the question then was, we've looked at pulsatility in the left side. What about VV ECMO? Is there a purpose of a pulse on the right side? Now, we kind of forget the left ventricle is so important, the right ventricle is so important, and the pulse is important. But we know that in acute respiratory dysfunction, you get RV dysfunction, and whether it's ARDS or an infarct, and we use mechanical support in this setting for ARDS or for other causes. And also we use VA ECMO in that situation, and in VA ECMO with pulmonary and RV dysfunction, we actually can show that we drop the blood flow to the lungs. We know this, that the pulmonary blood flow, as you increase the VA flow, you drop the blood flow that's going across the right. So I got interested in saying, what else does the lung do? And we kind of forget this. The lung is actually an endocrine organ. The lung has got a huge number of endocrine because 5 litres of blood goes through this massive microcirculation every minute. It's got endocrine cells, it's got type 2 alveolar cells, it's got a whole pile of cells. So the question is, with VV ECMO, and you're taking 2/3 of your blood supply with no pulse, the shear stress hitting the endothelium of the lung is entirely altered. And the question is, how are these cells affected by the lack of pulsatility? Because there's a huge number. These are all the things, and Vin's going to talk about GRP bombescin later on, but these are some of the pathways that the lung is involved in, and we suddenly assume that VV ECMO is just about oxygen delivery. It's not the case. We understand the renin-angiotensin system, so that's dependent on the angiotensin and the ACE, and the problem here is that the balance between the ACE and ACE2 is very, very important. But if you look at what ACE does in the lungs, it changes your bradykinin and kallikrein. So the question, and these things change your nitric oxide. So the question is, if you're altering your ACE, then you're increasing your bradykinin. You increase your bradykinin, this happens with reduced pulmonary blood flow. So we don't have much data on it at the moment other than to say, this is an area that needs significant look. We can see on animal models, and we're going to do the human work, but on animal models, VA ECMO improves circulatory function, reduces inotropes, improves microcirculation and mitochondrial function. The question is going to be what happens on the right side. And again, you love to think that you've invented something. We haven't. This was a paper from 1970 that shows when you do a Glenn shunt, you drop the pulmonary vascular resistance. And again, if you look at that, the low pulsatility changes the vasodilatory response. And with this in animal models, there's changes in nitric oxide. So there's actually data already out there that changing the pulse, not just to the left side that we started with, but to the right side, is changing what's happening in the lung level from nitric oxide, and again, soluble guanylyl cyclase changes in terms of pulsatility, and this is when you change this with pulsatility, this is the leakage. So perhaps this is part of the reason that when we put people, I almost said sheep, when we put people on VV ECMO, we see those lungs get worse before we get better, because it's not just oxygen delivery, it's pulsatility and it's an endocrine function. And we know that endothelial function is associated throughout with changing in outcomes. So the mechanotransduction, I don't think, has been looked at properly. Another nice paper, not from ourselves, looking at mechanotransduction, looking at how the epithelial and the vascular cell interact. So this is an area that we're looking at. These are some of the key areas that we're looking at. We're doing it in the mock loop before we go and irritate some sheep. And we're changing the pulsatility on a mock loop. This is what we do in our lab, which you're welcome to come to. And this is, we need to improve the size of the pulse. In the VA, we do clinical study. We need to look at the right side as well. And with that, I'll say thank you.
Fantastic. Thank you very much, Paul. Really inspiring talk, and you're selling pulsatile flow very well. Now, our next speaker is also from the same continent, Australia. Vincent Pellegrino is the director of ECMO at the Alfred. He's trained generations on provision of ECMO throughout his years. He's recently been made a fellow of the ELSO. Congratulations. And that's for his lifelong contributions to the field. Vince is a great man to chat with. I confess, I had a lovely chat with him yesterday. And if you want any advice about aging gracefully, then he is the man to speak with. Vincent, all yours.
Thank you so much, Noah. And thanks again for the invitation. I also provide relationship advice if you're in need of that. We're going to talk a bit about afterload. It's a great privilege to follow my friend John, who's recently received one of the higher awards nationally recognised by the Australian government for his contribution to research. So it's not all made up, some of it's actually right. I'll correct you on your mistakes in silence afterwards, yeah. And it's good to follow him, not just because it was a wonderful talk. It's good following because I think the topics are related, and there are thoughts that come into my mind when I hear the preceding talk that I think will be relevant to ours. So some interdigitation of ideas is a good idea. I don't make many requests, but just for this talk, just keep an open mind. We're losing the ability to disagree. And if we could just, if I say something that doesn't sound like what you were taught, just keep your mind open to the ideas of relearning and unlearning. I think the world needs that. All right, let's get going. I've presented these a couple of times. I'm a complete ECMO devotee over my life. I've introduced it and worked it, so that's the perspective of the talk. So the topic of the talk is afterload, right? And so people talk about afterload as if they know what it is, and it does my head in. And I wouldn't have to be here if there wasn't these sort of comments that just about lead every VA article that meet. And we'll start with the bottom one. It's more recent. I haven't cited these because I'm not trying to cause embarrassment. I'm just trying to disagree, if that's all right. So where it says peripheral cannulation for VA ECMO results in retrograde flow to the proximal aorta, substantial increase in left ventricular afterload, often leading to increased LV end diastolic pressure and decreased stroke volume. Bad, 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 bad ECMO, right? We've got it, you've heard it. Let's examine that a little bit closer. A lot of my learning came out of this book. It's an old book. It's a book when people used to learn from books. I think people learn differently from books than they learn from YouTube videos or other forms of learning, if there are some. And it explained very carefully that afterload is in that category of magic words such as patriotism and grounding that have very elastic meanings. But its use also fosters ambiguity because no one really knows what the person means when they say afterload. And it would be okay and just interesting if all it fostered was ambiguity, but it really has fostered a lot more than that. It's fostered this really expensive, deleterious, unproven rise in mechanical unloading that has occurred throughout the world. And many people will stand up here in talks straight after mine and say, unload everything. Everyone needs unloading. Go forth and unload. And it costs a bomb to do this. It's invasive and it's painful. So if you don't need to do it, you probably should think about whether you need to do it and understand why you're doing it. And that's what we're going to talk about today. So this is the largest ELSO data that looked at this, and unfortunately they capped off the data collection in 2019, and there was this huge rise in impeller, LV impeller usage, which has continued to rise spectacularly. And I think overall 40% of VA patients in the ELSO cohort had some form of mechanical unloading, which I think sounds way, way, way too high. So in terms of afterload, there's a few points about it, mostly taken from that book, which I believe to be a good source. So afterload is a laboratory concept initially when they were studying individual myocytes. When you try to apply afterload to an episodic phenomena, a pulsatile phenomena that starts and stops with blood flow, there are things to consider other than SVR and PVR because blood is a bit thicker than water, and when it stops it needs to restart, and that takes a lot of energy and a lot of work. And so understanding impedance or real afterload is much more than having a continuous flow analogy variable. I used this example this morning and I wasted a bit of time on the example. We can come back to it if you're really interested, but that's how you should understand the dynamics of flow in pulsatile circulations. It's on the left. So I'm going to have more time on this slide now. So this is a left ventricular pressure volume loop. John showed some in the previous talks. We're just going to go back and try and explain it in a minute or two. Sorry. Oh, look at this. Okay, so we're going to start there, which is the start of systole. You get isovolumetric contraction. This is a left ventricular curve. And then it goes up. The aortic valve opens here. and blood starts to emerge, so the volume comes down, and then the aortic valve closes here. And one of the things that's hard, like measuring all the aspects of impedance can be hard, but all of the information you need is contained in the joining of those two dots. And that relationship is called the EA, the elastance of the arterial system. And its units are elastance. And that angle there. And then what this paper does, and a whole lot of other papers just like this, will all go and give you the same message, that when you put this patient on VA ECMO, the brown line, the brown dotted line, is the systolic function. So this person has reduced systolic function because this ventricular elastance is down. And as we turn up the ECMO, we get a higher and higher afterload, or arterial elastance, and the EF gets worse and the diastolic filling pressures get worse, right? So that's the example of that. If we could just challenge that from our... So this is put a different way. We have a rise in end systolic volume, we have a rise in end diastolic volume, we have a rise in stroke work, and we have a rise in end diastolic pressure, all with increased flow. But what they're not telling you is that this is also happening. So the blood pressure is going up. So it shouldn't need stating that when you take blood out of the veins and you put it into the arteries, using a powerful pump, the pressure in the arteries goes up. And the more you do it, the more it happens. Sorry. So that's it. Now the point is, all of this is controllable. You control the blood pressure. You have drugs to control the blood pressure. So turning up the ECMO and not controlling the blood pressure, that's on you. Anyone who does that, that's on you. That's not the ECMO's fault. That's your fault. And if you do that and walk around and say the patient's failing because of the ECMO, but you haven't lowered the blood pressure, well, that's a disservice to the patient. This is an example where they've cited that the effects of ECMO on the ventricle have caused that change in the left ventricular loops. And I'll just show. So if you draw a line through each of them, they're exactly the same. The only thing that's happened is the blood pressure's gone up. The impedance hasn't actually changed, the afterload. And so blood pressure is one thing, but there's a whole another thing, and I was at Michael Pinsky's talk on heart and lung interactions, and I got lost halfway through, but this is simple, right? If I could try this again. The job of the right ventricle, up here, is to take blood from outside and put it into the chest, run it through the pulmonary circulation, right? And the job of the left ventricle is the opposite. It takes it from the pulmonary circulation and puts it out into your body. So if the pressure in the thorax goes up, the job of the left ventricle gets easier, the job of the right ventricle gets harder. It's the perfect balancing tool for LV distension in patients. And it's so important and so fundamental and never talked about. It's a real gap in practice. This is a patient with a chronic cardiomyopathy that got ECMO, and you can see they're on support. We put them on awake because we want to keep the patients awake if they can. They start coughing, getting short of breath, naturally, because this heart can't cope with the change in pressure and the change in circulation. But if all we did was put the patient on the breathing tube in for a few days, the heart comes down, the lungs are clear, we can support this patient safely to the next phase, because none of this is going to make the heart better. We have to remember we're just trying to get somewhere else. So that's such an important point. So don't get me wrong, don't over call it. There is a place for mechanical unloading in significantly unbalanced heart failure syndromes, but it does require some thought. Most of the unloading data that you'll see in meta-analysis and trial data is actually favours balloon pumps rather than the addition of impeller pumps. But extreme caution is required when we look at these propensity matched or trying to match these non-randomised comparisons. Most of the use of these impellers is driven by something other than a physiological reason to use the impeller. I think impeller is a great tool on the left side for left-sided features, and VA ECMO does have challenges to run. Like you've got to be careful in doing it. But we need to understand what we're doing before we go ahead and do it. And we can finish with this, sort of one of my favourite games, which is let's blame the ECMO afterload, shall we? So if this is your patient, and they're very similar to the one I've just mentioned, they've got a chronic dilated cardiomyopathy that's decompensating. We would see this really commonly in young people with alcohol and amphetamine or cocaine use, which is pretty common in a lot of Western societies. And they often present with decompensated states like this. And now you can see smoke in the left ventricle, you can see hugely unbalanced side. So if we put this guy on VA ECMO and turn up the flow to 5 litres a minute, are we surprised that the lungs flood and the patient dies and there's a aortic root thrombosis? I wouldn't be surprised at all. But there are ways to do it, and we've done it in the past really successfully, which is just do it timely, do it earlier if you're going to do it rather than later, and that will help maintain pulsatility, and you'll need less support rather than more support. If they arrest with this chronic condition, they're done for. ECPR from here, too many steps in the recovery. I would not recommend it at all. And don't spin the wheels. Don't put your foot flat on the floor of the accelerator and spin the wheels of the car. We go on slow in this case. We go on respectfully. We make sure we've got drugs to control the tone in the circulation and the afterload in place before we start. Probably better to do this case intubated rather than extubated. And there's no point doing any of this unless there's a long-term plan for this patient. If we're going to say he's not suitable for anything, then why did we start making those things? So we're just about done. We can skip that. This is what LV distension, where you get pump-driven failure, looks like, but it's a slightly different talk. So in terms of the populations and the use, we can just run through it. This is a great study that shows who gets LV distension syndromes and how often they occur as a whole run. And basically about 30% of VA patients can be prone to it and require some understanding and careful titration of other therapies. The commonest groups in multivariate analysis were the ECPR group, and that shouldn't surprise anyone. And on univariate analysis, AMI was trending towards being much more likely, which makes complete sense. And primary graft dysfunction, which is a right heart syndrome, trends the other way. So I think they're all really believable findings from a cohort study. So the last few slides is just a summary of how we can go about it. For the cardiac arrest people, there's often only a short period of time where you have a stunned ventricle that doesn't want to face or can't pump much against much pressure. But that often gets better quite quickly as a group generally. And so putting in an expensive device for a few hours of support rather than turning up the PEEP doesn't make a lot of sense to me. We can get back on that group, and that group hardly ever needs trips to OR because they haven't woken up from their cardiac arrest and their brain might not be worth doing other operations on. So that's that group. The bridge to VAD group now has a lot of options, and VA ECMO may not always be the best way to get them to their destination. Impeller will become probably more useful in that group. But it can certainly be done. The AMI group is a real concern. It's a very hard group to change outcome in. I think we want to be really careful whenever we apply VA ECMO to big AMIs. I think unless they've got really good revascularisation potential, we shouldn't probably do it. And myocarditis is a wonderful condition. It hardly ever requires LV venting, can just be supported with ECMO, and it gets better, and it has the best results. So with that, thank you. Thank you all to the organising committees for bringing us out and having the meeting.
Thank you very much, Vince, for that very, very interesting talk. I have the pleasure of introducing Dr. Lorenzo Del Sorbo next, who is an intensive care physician at Toronto General Hospital and an associate professor at University of Toronto, who has trained many people like me And today we have the honor of listening to him talk about one of his main academic focuses, which is the application of strategies to prevent lung injury and ECLS as well. Thank you very much, Dr. Del Sorbo.
Thank you, Mama, for the nice introduction, kind introduction, and thank you to the organizer for such a beautiful meeting, very inspiring. It's very challenging to give this talk after the talk of two eminent investigators that really provoke with their hypothesis and really advance the knowledge in this field. So I want to, I'll try to give some inspiration as well and talk about association between daily driving pressure and mortality in patient on VV ECMO. So we switch from VA ECMO maybe a little bit to VV ECMO for ARDS. I don't have conflict related to these talk. So VV ECMO is a very potent machine that control gas exchange very effectively with the extracorporeal means, of course. Applying patient with very severe ARDS, as I said a couple of days ago, these patients have a very high risk of ventilator-induced lung injury because their rated part is very small, they have very low compliance, so very easy to induce overdistension or to have atelectasis trauma. Patients that fail conventional intervention like prone positioning or high PEEP, when they're on ECMO, mechanical ventilation is not absolutely necessary, as I said, to facilitate gas exchange. So the paradigm here is different. Our approach to mechanical ventilation, should we ventilate these patients? Should we use what type of volume should we use? And yet the mortality in this patient is still fairly high. So is there any way we can optimize our treatment and to improve outcome in this patient? So how do we ventilate this patient? So if we go to the guidelines of the ELSO organization, they're saying ventilator settings should be chosen to limit ventilator-induced lung injury. And we heard beautiful talks in the past few days and this morning even from Arslasky about that. However, optimal ventilation strategy in patients with severe ARDS undergoing ECMO is not well defined. So let me show you the vent settings of the patient enrolled in the OLIA trial. You can see PEEP was fairly high, plateau pressure very significantly lower as per protocol in the red group that underwent ECMO. Driving pressure also very low. So does ventilator-induced lung injury still occur during VV ECMO? Or VV ECMO allows us to reduce vent setting this much that ventilator-induced lung injury doesn't exist any longer in this patient. So let me show you a few data here. This is a very nice retrospective study, observational study by Tai Pham and Laurent Brochard from the RIVA group, analyzing patients on ECMO for ARDS from H1N1 infection. They show, interestingly, that the plateau pressure the first day of ECMO was independently associated with mortality. So, suggesting that, and plateau pressure is something that we can really change on in patient on ECMO. Suggesting that may be a signal of ventilator-induced lung injury. Similar result in this other observational study by Ari Serpa-Neto and Marco Schulz, again, suggesting that there is ventilator-induced lung injury. In fact, driving pressure day one of ECMO was independently associated with mortality. This is more recent data from Joe Tonna and Martin Erner showing that the dynamic driving pressure the first day of ECMO is associated with mortality. This data from the ELSO registry, more than 9,000 patients enrolled, so robust study. We studied this issue in a crossover physiologic study in Toronto. We studied 10 patients with severe ARDS that were treated with ECMO for less than 72 hours. Our protocol is of ventilation in Toronto is following the CESAR trial, so we're ventilating them at baseline with pressure control of 10 PEEP of 10. And then we switched ventilation to either CPAP for 2 hours or increasing driving pressure to 20 over PEEP of 10. And this was applying random orders and then go back to baseline settings. This is the tidal volume generated by these settings. You can see very low tidal volume, less than 3 ml per kilo predicted body weight. And we show that there was a linear correlation between change in driving pressure and change in inflammatory mediators. Here is projected the concentration of IL-6. Okay, so a linear correlation between the change in driving pressure and the change in biomarkers released in the bloodstream, despite very low tidal volume, very low tidal volume. Other data comes from this observational trial by Luciano Gattinoni, very interesting in different indication for VV ECMO. They try to reduce work of breathing, and they use respiratory rate as a surrogate by increasing sweet gas flow, and clearly show that whereas for more chronic indication of VV ECMO, the effect of increasing sweet gas flow very significant, less so in patient with ARDS, whereas only a third or half of the patient really responded to these treatments, suggesting that maybe these patients are higher risk when they are in spontaneous breathing of developing self-inflicted lung injury. And indeed, in this very nice and often presented case report by Tommaso Mauri and Antonio Pesenti, it was very interesting in this case where patient in control, in volume control ventilation with the tidal volume of 4 ml per kilo with peak pressure 37 and low transpulmonary pressure was switched to pressure support. All the data that we can see on the ventilator were actually better tidal volume, lower peak inspiratory pressure, but yet very high esophageal pressure swing, resulting in extremely high transpulmonary pressure, okay? Which usually we don't measure at the bedside. So this patient high risk of developing potential self-induced lung injury, self-inflicted lung injury. More recent data from the Lifeguard study by Matthew Smith and the group of Lancome, multi-center observational trial, 350 patients on VV ECMO with ARDS. They didn't show any association of vent settings and outcome. There were probably some methodological issue. They used a time-dependent Cox model, considering ventilation settings as endogenous covariate and informative censoring to patient dying and during follow-up. So with the help of the chair of this conference, Abdulrahman Al-Fares, we decided a few years ago to do the Remavo study. Abdulrahman was very good in measuring esophageal pressure, esophageal manometry every day of ECMO run for the entire duration of the ECMO for a year, all the patients undergoing ECMO for a year. So we studied mortality among these patients, it was very high, and we wanted to identify target ventilation variables that were associated with mortality. So we studied static driving pressure, dynamic driving pressure, transpulmonary driving pressure, esophageal pressure swing, and see and analyze their association with 28 days mortality. So we use 2 cohorts of patients. We had a retrospective cohort of 75 patients on VV ECMO with these criteria in a time span of 10 years, and then a prospective cohort of 40 patients during 1 year where esophageal manometer was measured daily for 28 days. And then we follow the patient up to 28 days and record death, decannulation as per protocol. We use a Bayesian joint model using Latin subject-specific random effect and correcting for endogenous covariate for patients that were dropping out to death, and accounting for changing disease severity and ventilator settings daily over time. And we adjusted for age, sex, respiratory system compliance, SOFA score, and Apache score. See here the baseline characteristics, the usual characteristic of patients undergoing ECMO for ARDS. Here are the baseline vent settings. You see very low tidal volume per predicted body weight, low driving pressure that was equal survivor, non-survivors at the baseline, and no esophageal swing, as most of these patients initially were deeply sedated or paralyzed, and very low mechanical power. In these graphs are shown the longitudinal profile of dynamic driving pressure, static driving pressure, and transpulmonary pressure stratified by survivors in black and non-survivors in light blue, as you can see. And these are the graphs representing esophageal pressure swing in tertile. So in red or pink here, very high effort, intermediate effort in green, and low effort in blue. Divide and stratify again by survivors and non-survivors, quite dramatically showing has a good inspiratory effort, not too low or not too high, is maybe associated with the outcome. And in fact, our analysis showed that any daily increase of dynamic driving pressure was associated with a 1.16-fold increase of the hazard of death. And we didn't find the same signal for daily static driving pressure or daily transpulmonary pressure, where we find association between high inspiratory effort as measured by esophageal swing and low daily, again, inspiratory effort as measured by esophageal swing. Interestingly, when tidal volume was, if tidal volume increases over time, it's possible that it increases because the compliance increases and the patient is getting better. But when tidal volume was resulting in increase in dynamic driving pressure, that was associated with increased mortality. And the same, we found that when high effort, so high esophageal pressure swing led to an increase in dynamic driving pressure that was also resulting in increased 28 days mortality, suggesting a mediation effect here. So in conclusion, we can say that VILI can occur at any time point during ECMO support, even if we use very low tidal volume or low pressure ventilation. And dynamic driving pressure and esophageal swing or workup breathing may represent adjustable variables to guide mechanical ventilation in this patient to potentially improve their outcome. I want to thank all the staff that contributed to this result, and particularly Abdurrahman that did a great job in Toronto as well as here. Thank you very much.
Thank you very much, Lorenzo, for sharing that. I have the pleasure of introducing our last speaker today in this session. It's our Associate Professor, Emma Ridley, who has a very impressive CV. She's the lead of the nutrition program at NHMRC Emerging Leadership Fellowship. She works at the School of Public Health and Preventative Medicine in Monash University in Melbourne, Australia. She is responsible for the strategic development and leadership of critical care nutrition program at the Australian and New Zealand Intensive Care Research Centre, and she's authored more than 95 publications, very high impact journals, and she'll be speaking to us today about nutrition support for patients on ECLS. Thank you.
Thank you once again for the invitation to be here, and it's great to have nutrition included in this quite medical session. I think that's excellent programming. I also should add to that bio, I've been a clinician for 20 years with 18 years within ICU at the Alfred, and in that time I've seen our ECMO service from the very beginning to now what it is, which is a significant service within our country, and one of the best, I think, and recognised internationally for that. So I also bring that experience to you, which is probably more relevant to today. A few disclosures that are not relevant. So I think the first question we should ask is, should nutrition care be different for patients who receive ECMO? And I think in some ways, yes. So they're often very unwell, and I'll talk through that. They often have pre-existing chronic illness, and that is important to consider. They often have a long length of stay, and that's critically important when we think about nutrition. And obviously ECMO can have a devastating impact on functional and quality of life outcomes, and that's where nutrition probably can come in terms of rehabilitating these patients. I think it's important we have a look back in time, and I just wanted to share my reflections from working with the ECMO service, and I'll come back to this towards the end. But in the very beginnings, we had very limited literature. There was pretty much no studies on nutrition, and so we just were flying blind when we were seeing these patients. They were notoriously hard to feed. They had high intolerance, and we were unable to get good volumes of nutrition into them for that reason. And it's been really interesting watching our ECMO service develop, and we have found that as our doctors have become much more experienced and better at providing ECMO, so has our ability to feed the patients. And I guess I'd share that reflection if you're working in a newish ECMO service. Sometimes at the start, these patients can be very difficult to feed if they're a bit unstable. They're often very shocked, very unwell, and that can impact on our ability to feed them, and so that's definitely been our experience. In the early days, so I'm talking, 15 years ago, so please don't take this as current evidence, our philosophy was to feed more. We thought they were hyper-inflammatory. We thought they had higher requirements. They needed more, so we were trying to aim to push that. Sorry, that's a typo. It should say 25 to 30 kcals, not 20. High protein. There was also questions around the circuit inducing inflammation, and we were concerned about that driving catabolism. That has changed. We now know that those circuits are not doing that. And there was also concern around the loss of macro and micronutrients through the circuit, and so perhaps we need to feed more to overcome that. And so that's just some reflections of how it was in the early days. Because there was no literature and we are at an academic centre and we started doing more and more ECMOs, we thought we would actually contribute to some of this literature. So this is one of the first publications on ECMO and nutrition, and it's from the Alfred, and it was a retrospective audit, and we looked at how can we feed these patients, and we pretty much documented what we thought, which was they were pretty hard to feed. They were receiving about half of what we predicted them to require. A lot of them had prokinetics, and a good portion of them needed parenteral nutrition. We then followed that up. So this is a multi-centre study published in 2015, and we included 107 patients from 8 ICUs, and we looked at how much nutrition they were getting. I'm sorry it's not presented in the same way. That's just the data is not presented in the same way in the papers, which is annoying. But we found that we were providing probably a little bit more nutrition than previous. So maybe our centres were becoming more experienced and we were able to do it that way. Recently, this is my PhD student Claire, recently we have repeated this, so it's been 10 years since that study I just provided prior. So we've repeated it and we're going to do a 10-year comparison to see how things are different. And what we aim to do with this was a descriptive study once again, but the key difference here is we've followed the patients to the ward, and I'll talk about that as well because we think that is a really important part of this. So we collected data over their ECMO stay. We linked with the Excel registry, which is a registry led by Professor Carol Hodgson from my centre, the ANZIC-RC, and so it's registry linked, and we're going to follow the whole hospital journey compared to just that ICU stay, because we know that long-term nutrition is probably the most important aspect. And as I said, it's the first study, or will be the first study to look at the ward process for these patients. What we've shown is, and this is not published, so please no social media, it'll be submitted soon. What we've shown is that the energy and protein delivery is less than previous, and I think that reflects a change in practice. We now have evidence to show that we should probably be pulling back in these sick patients, and I think that's what we've seen here. I hope that's what we've seen. We've also done some other work looking at what might be impacting nutrition. So this is another retrospective study, including some investigators from Queensland, and John is one of them, looking at different aspects and how we might be able to feed them. And we did show slightly different adequacy between VV and VA, although duration on ECMO and ability to feed the patients probably confounds here, so it's probably a bit difficult to interpret. But we did show that if the patients had a 5,000 ml increase in fluid balance, there was an associated decrease in nutrition adequacy, probably indicating that sicker patients are harder to feed, I assume. We have also looked at, is there any association between nutrition and markers of muscle? This is a very small sample, but we just wanted to have a little look and see if there was any signal or indication for that. We found no association in this sample that nutrition was impacting muscle measures in patients who are receiving ECMO. And so it's a complicated place to work in and probably indicates that these patients are very sick and perhaps nutrition in the early days is not going to overcome some of these issues, which reflects the evidence in a wider population. What about energy expenditure in patients on ECMO? So this is a big evidence gap because we cannot do traditional indirect calorimetry from the ECMO circuit. And this was investigated by a group of from Europe, and they came up with a very complicated calculation that allowed them to do this process. And so they did a pre and post oxygenated gas. They did an indirect calorimetry measurement at the patient, plugged the gas result into a fancy equation and came up with an energy expenditure estimate. It's important to point out we can't validate this model. It's too difficult. We can't do bomb calorimetry, for example, or direct calorimetry to validate this, but it does give an indication of energy expenditure. And so this group showed about 26 kcals per kilo, and they did show that there was difference between predictive equations and their model in terms of predictive ability to match energy expenditure. A different process was done by Elizabeth de Waal from Belgium, and they did an indirect calorimetry measurement on the circuit. I don't understand how they did that, but they did that, and then they did an indirect calorimetry measurement on the patient. And they showed in a group of a small study again, but these studies are very difficult to do, around 21 kcals per kilo. So remember at the start I said we assumed they were hypermetabolic, they were inflamed, they needed more nutrition. The data that we're getting at this point is showing us that that's possibly not the case. We saw that there was a gap in VA, so there's mostly VV that people are looking at. There was a gap in VA, so we actually planned our own pilot study looking at VA ECMO. We used the first study that I showed, so we did pre-post oxygenated gas and an indirect calorimetry measurement at the patient. 21 patients. This took about 2 to 3 hours per patient, so very time consuming, and if you wanted to roll it out into practice, again, it's very time consuming. But we again showed that in the early phase of illness, it was around 22 kcals per kilo, and later on in stay, so around about 5 to 7 days, it had increased to about 25. So definitely these patients are less hypermetabolic than we initially thought, and all of these studies, even though they're small, are suggesting the same thing, so I would suggest that that is a correct signal. So with all that in mind, how should we provide nutrition to patients receiving ECMO in 2025? I think just like other patients, at least initially, but then there's some important considerations after. We are in the less is more era for nutrition early on. We were previously in the more is more era, in case you're wondering, and we're not there anymore. There's multiple large-scale RCTs that now show no indication for benefit with aggressive feeding strategies and a potential for harm early in critical illness. And this is highly relevant to ECMO patients because they are our sickest patients. This is a number of trials that have specifically looked at nutrition and ECMO. So there's none, not one. And so we need to address this gap, and hopefully this is something that our group will start to address. But we can bring across the literature that we have in a general population, but there's nothing specific to ECMO. What I think is relevant to patients who receive ECMO is some of the recent literature. I'm not going to go through all of it, but this is Nutria 3, which large study, 3,000 patients, specifically focused on patients with shock. They're very sick, obviously SOFA score of 10. And they looked at 6 kcal per kilo per day compared to 0.2 to 0.4 of protein versus what they called was usual care, 25 kcals per day, over the first 7 days. And they did show that time to readiness for ICU discharge was lower in the low-calorie group compared to the usual care group, so a benefit for that low-calorie group. The outcome they've used can be criticised. It is subjective, and so people have criticised that potentially, saying that might be a problem. But I guess taking all the literature that we have, there is potentially a signal that this might be beneficial, and I think that's very important for patients who are most unwell. What about protein? Well, everyone thought, well, okay, energy maybe isn't the answer, so it's got to be protein. We've got to give more protein. So several studies started to answer that question, and the first that was published was the EFFORT protein trial. It came out, I think, early 2023. There were 1,300 patients. It was planned to be 4,000 patients, but due to COVID, they had to re-estimate their sample size. So that's just something to take into account. And they looked at their alive hospital discharge or mortality at 60 days, and they found there was no difference. Importantly, there seemed to be a signal for harm with higher protein provision in patients that had acute kidney injury and more organ failure. And so this is important for patients who are receiving ECMO, who often have both those things. And so this was definitely, it was the first trial to come out, and it's definitely made all of us think, okay, we definitely need to be pulling back both energy and protein. And then secondly, just last year, this PRECISE trial was published. It's 935 patients. They used a patient-centred endpoint of EQ5D, which is quite nice, not usually done. And they looked at up to 180 days post-randomisation, and they found that quality of life was lower in patients allocated to the high protein group. So again, all of these studies are pointing towards the same thing, that in that early acute period, aggressive nutrition is probably not what we should be doing. They also showed there was higher incidence of symptoms of gastrointestinal intolerance. We have seen that in the calorie or energy trials as well. And so really, potentially, is this the body telling us something around what it doesn't want in this period? And I think I bring you back to feeding in the early days, and I refocus on these patients were hard to feed, they have high gastric intolerance, they ended up with low nutrition adequacy, and is this the body telling us something? And I think that's really where we've come to this less is more era. So why is there no indication of benefit and perhaps harm? So let's just have a look at that. So it probably comes down to timing. So we've got the acute phase, which is that early phase, characterised by very shocked patients, very unstable, really just trying to make them stable and survive at that point. This is followed by a period where they're becoming more stable, things are more calm, and perhaps we can get started with some nutrition in this period, slowly start to titrate. And then we follow the late rehabilitation phase, which perhaps is the most important period for nutrition. And this potentially is we're going to rehabilitate our patients. It's really important to note, though, that all trials are focused in this early period, so up to about 7 days. And so when I talk about low dose energy and protein, what I'm talking about is in this first 5 to 7 days. This is where the data exists. We have very minimal studies that have looked at this late period, but we think that this is going to be very important from a nutrition recovery point of view. We just have to work out what that time point is. It's likely that it's going to vary for different patients, and so that's a complication we're going to have to address at some point. So what should we do? I know you're probably thinking, well, now we're really confused, so what do we do? So recently, a group of us wrote this editorial just talking about what we should be doing. I think it's highly relevant to patients receiving ECMO. Just keep in mind, this is not a guideline, this is an opinion based on current evidence. The guidelines have not been updated yet since the development and the publication of the most recent trials, so it will be interesting to see what comes out of them when they do. So in that initial period when the patient is very sick or deteriorating, what should we do? We should just be starting something. And I'm not saying withhold nutrition, I'm saying starting something slow. There is evidence to show that just starting nutrient protects against infection, it maintains gastrointestinal mucosa, and it is important to get something going. There is a risk of gastrointestinal ischemia with high-dose enteral nutrition, but low-dose enteral nutrition can still stimulate blood flow, and that potentially could be protective against ischemia. And so we should be starting something. But we're talking about very low amounts. And if the patient remains unwell for days, you will continue this for days until they come out of that phase. Once they become more stable, so you're thinking, okay, inotropes are stable, perhaps we're de-escalating, maybe we're reducing the number of agents, we're feeling pretty comfortable here, things are looking okay, you can start moving through to slowly titrating nutrition. And you would continue to do that as the patient progresses up to about day 7. It's very important, though, to keep asking this question, has the patient deteriorated? Because patients can jump through these phases. So I've shown you, a diagram of the phases, but they don't necessarily stay in one phase. They can go back and become more acutely unwell. So it is very important that you ask this so that you can titrate your nutrition. It's been really interesting watching our nutrition process change, and so our unit is fantastic. They start nutrition very early, but our job now has almost become, sometimes we go in and we actually say, can you slow down? Can you turn it down? Can you pull back a little bit, which is not what we used to do. We used to be going in to say, we need to give more, we want to enhance this, but now we say to our teams, can you actually pull back because we're concerned this patient is quite sick. And so it's really been interesting to watch the change in practice. Just a note on enteral versus parenteral, because I know this can be a little bit controversial. There has been some musings around parenteral nutrition, particularly contributing to failure of filter in ECMO patients. And I've not seen any hard data on that. It has been a concern, but I've not seen any hard data on that. Also, in our practice, we use quite a lot of parenteral nutrition in these patients. We're a high-volume ECMO centre, and I'm confident that if there was a problem, we'd probably know about it, but that's just opinion. Guidelines have changed around the use of parenteral nutrition, and so there's varied strength of recommendations. This is the most up-to-date one, so this is from the American Society of Parenteral and Enteral Nutrition. They now say that EN and PN have similar risk, and essentially what we're talking about is overfeeding is bad regardless of the mode that you use. So it's not about EN or PN, it's about overfeeding, essentially. They also say between 12 to 25 kcal is acceptable in that sort of initial period. And they also say there's no benefit of supplemental parenteral nutrition prior to day 7, and I'll just talk about that in a moment. In terms of parenteral nutrition, you're probably aware EPINIC was the largest trial that's been done. It showed harm back in 2011. It looked at early initiation of parenteral nutrition on day 3 compared to late initiation on day 8.
2 minutes.
And they clearly showed an indication for harm in terms of discharge alive and time to discharge from the ICU. But no other studies have replicated that. So there are several other studies looking at enteral versus parenteral. They have not shown the same signal. And I think that early study was really about overfeeding, over-provision of calories. That was where the harm was coming from. To be fully transparent, these studies have not shown clinical benefit either. They've just not shown a signal for harm. That's where the guidelines come in and say, well, we say no parenteral nutrition before day 7. To me, in my practice, that doesn't make a lot of sense. If I have a patient in front of me who I know is going to be here for 3 weeks or more, I'm not going to withhold nutrition from that patient for 7 days. What I'm going to do is start the conversation around about day 3 and say, okay, I think this is where we're heading. We'll start very low, we'll start very slow, but we're not going to withhold nutrition because that doesn't really make sense to me. That's just my practice. You might disagree, but that's what we do. We have to think about later in ICU and transfer to the ward. And so I just want to highlight this. You'll see there's a question mark there, and that's because we really have limited data in this post-ICU period. And so this is the period we think that nutrition rehabilitation is going to be important. What do we know about this? Well, there's several papers that have looked at this about the post-ICU or the late ICU period. And what we know is that nutrition provision is very poor. It's very low with oral nutrition alone, and there's multiple barriers and no solutions. And we know our patients leave ICU with a big nutrition deficit in most cases. And we showed this in that original paper. So patients were leaving with about a 2,000 calorie deficit and about 325 grams of protein at the end of their stay. Just a basic nutrition principle for you: if you want to lose weight, you or anyone, half a kilo to 1 kilo a week, we need a deficit of 500 to 1,000 calories per day.
We're almost at time.
This is the diet. Yes, thank you. This is the diet that we have our patients on, and so we need to be mindful of this. We're trying to get them better. We're trying to recover them, but we have them on a weight loss diet. Does this matter? I'm not sure, but it might matter if the deficit extends. And so we do have this data on the post-ICU period, and so we'll be looking at this in terms of any interventions we might be able to intervene. So a long-term view of nutrition: the patient's journey does not end when they leave ICU. Leaving hospital with malnutrition is not a good treatment outcome, and we need to try and do everything we can to prevent that. Pay careful attention to nutrition across all phases of illness, very low when most unwell, and optimise in recovery, because this is the evidence that we have currently. And the recovery period is probably the most important piece for nutrition rehabilitation. We've come a long way, there's still a long way to go, so please keep nutrition in your mind when you're looking after patients on ECMO. Thank you.
If we can invite our speakers up on the stage. And we invite any questions from our audience. I might start off a question for Dr. Del Sorbo. Probably a basic one. Over the last 3 days, we've heard a lot of talks on the impact on mortality of over-sedating patients or prolonged sedation in patients, not necessarily over-sedating them. One of the things that I wanted to ask is, how do you balance, and what is your approach and your opinion on balancing, over-sedation and control of driving pressure along with, the impacts on mortality that we know from sedation and paralysis?
It's a very, very good question. So I don't know. Our practice is to try to reduce sedation drastically and very early on, okay? And but there is over sedation even from our data. So when the esophageal swing is 0, okay, that's associated with very bad outcomes. So over sedation we know is very bad. If targeting a certain esophageal swing or certain inspiratory effort will lead to better outcome, is the data that I showed are hypothesis generating. Will need to confirm in a new study. And there are lots of ongoing study regarding this, so hopefully we'll have a better idea of what a standardized protocol should look like. But at the moment, there's no data justifying or one way or the other to manage this patient. Definitely, we know that every sedation is bad.
So at the moment, at the bedside, what do you do?
Yeah, so we lower the sedation. We let the patient spontaneously breathing or generating spontaneous effort, as long as there are prudent and modest physiological target achieved, meaning oxygen saturation, the usual target of patient with ARDS. Okay, and the interaction between the respiratory system and ECMO is at times very complicated, though, because the cardiac output changes if the patient is more awake, and so the physiology is a bit more challenging to manage as well.
Just as you're getting the next question, another thing we did in one study is early tracheostomy allows you to significantly reduce the amount of sedation. There's a study we did, it was single center, and then I think we did one with the Alfred too. So it shows less sedation, and with that less sedation, less positive fluid balance, because propofol is a vasodilator, so is fentanyl. So you can get people spontaneously breathing, less sedation, less positive fluid balance, and we know in outcomes in ECMO, the more positive the fluid balance, the worse the outcome, and also the bigger rise in renal dysfunction. So I'm not saying that everyone needs an early tracheostomy, but if you think you're going to be there for a while, again, we were taught by Vin at the start, don't trachea, and then we learned from the team at the Alfred that as long as you did it well, it was relatively safe, and it did allow you to wake the patient up much more comfortable for them, and other benefits in terms of vasoactive fluids, etc., etc.
I want to follow up on that. Not only the trick, I completely agree, but the position of the cannula is crucial there, okay? Because if the draining cannula is not in the right position, every inspiratory effort can lead to a change in ECMO flow, which is very bad. And we learned this lesson and find the solution, thanks to Vince. So I don't know if you want to comment on that, because it changed really our practice, and the ability of reducing sedation in our patient was much more successful after we apply the strategy that Vince taught us. And thank you again for this.
Thank you for the acknowledgement. I think it's a really complicated access, and a lot of people think that VV ECMO is simpler than VA ECMO because you just have to cannulate the veins, but it's actually much more fraught. And the most difficult part and the most painful learning lesson over many years for us was the position of the access cannula. And this was made worse when multi-stage cannulas became more available. And we didn't realise why, if you were draining a swimming pool, a multi-stage cannula would help you empty the swimming pool. But because you're draining from inside a collapsible tube, and most of the blood comes in the first hole. So they're not designed to spread the load out over the length of the side holes. They just take most of the blood at the first hole because the hole is too big. And so all that negative pressure from the pump is transmitted there. So that has to be quite high, which means the tip has to be 20 centimetres higher. And that was important. And so once that's in, and then the issues with sedation and the probably the only thing to add to what's already been said is desedating should be encouraged because you can always reverse that step. We have a pretty hard limit of 30 days of protective lung ventilation. And if the process is still, as a lot of our COVID patients had, at 30 days, if they still got really disordered breathing and respiratory profiles, we ceased caring. The sedation went off. They were either extubated or tracheed, and we just ran it with the ECMO and looked the other way. And because it's a time-limited intervention, I would say. And extubation on ECMO is actually quite possible. And the commonest mistake people make is just not putting the tube back in. So if it turns out bad, they start, sedatives or something. Just put the tube back in. It didn't work. But trying it is a very good idea. It shouldn't be left out.
Thanks, Vince. Any questions from the floor? I've got a question, if that's all right. Prof. Fraser, thank you very much again for a fantastic talk. Could you kindly elaborate on the effect of pulsatile flow on the LV afterload, if that's okay?
Yeah, it's an area that I've had lots of discussion and argument with people in the past. I think the best way to, allude to it is basically the balloon pump allows dropping of the afterload, the diastolic timing of it and the opening of the valves. So the fact that you've got a pulse built in and then a drop of the pressure allows the valve, we think, and we can see it on the sheet model, to drop out. Once you put in PV loops as well, you can see that too. So I think it's the pulse and the up and then the down part is what's happening. We have a whole pile more work to do, but the early work suggests we've got it. If we can make the pulse bigger, we think it'll do it better. Definitely, and again, I go back to the illusion of the balloon pump. Balloon pumps were good when they were doing one-to-one, but when they get really fast or atrial fibrillation, they were terrible. And you just settle down and think, I don't know what to do. At the moment, the pump is not good enough at pulse rates above 120, 130, and they're the ones that you probably really need the benefit. They're the really sick ones because cardiac output, heart rate times stroke volume, the stroke volume is going down, the heart rate's going up. They're the ones that you will probably start to see a benefit because the delta. We haven't got that right. So that's back with the engineers and the medics working to see how can we do that. And I think once we get one-to-one ratios sorted at the really fast ones, a bigger degree of energy transfer at the blood level, I think we'll be able to come back in a year or two, inshallah, and show you better data.
Very much.
I have a question for Professor Ridley. There is some talk, you can educate me a little bit more on this. So you mentioned the early phases and, being cautious in the early phases about aggressive feeding. And then you mentioned the recovery phase. My question is for that in-between phase and the deficit that you might incur from early phase slowing down of feeding and not being aggressive. Is there any evidence to guide us on, catch-up feeding or covering that deficit earlier on that could help us in that recovery phase?
Yeah, great question. The answer is no, there's not. I think what we know now is we just have to tolerate that deficit that's going to accrue early on. But I think we really need to flip the switch around that 7 to 10 day mark if they're coming out of that acute period, and then really try and optimise not extending that deficit. And so the way that we would do that is if they're still unable to be enterally fed to an acceptable level, and for us that would be around 80% of what we estimate they need, we then add in parenteral nutrition as a supplement to enteral nutrition. So we always try and go with enteral nutrition. We'll always try and continue enteral nutrition, but we do use parenteral nutrition to top them up. Post-pyloric feeding is also an option, but in our centre we have to wait a long time to get those tubes. It's not easy for us, and we often find by the time we've bridged them with parenteral nutrition while we're waiting for the tube, the issue's resolved and we get them back on enteral nutrition anyway. So I think around that 7 to 10 day mark is when you really need to flip your attention and start thinking differently, particularly if you know they're going to be long stay, and that's when you really try and optimise it. If they're eating, that's a whole nother story, because we have huge issues with appetite, with nausea, with actually optimising their nutrition. And so that is hard work, and we try and continue enteral nutrition until they can manage their oral nutrition. Yeah.
Thank you very much. And for Dr. Fraser, this might be more of a basic question.
I'll give you a basic answer then.
I'm probably early in terms of the concept of pulsatile ECMO. The question that I have is, at what point do we consider, or how aggressive should we in terms of returning native pulsatility versus providing pulsatility via, a circuit?
It's a really good question. I don't know the answer. So there's a really basic answer. Look, I think evolution, how we are, pulse has got a benefit. We did some work in a thing called Biovic or a bionic heart, and when we started it, the pump, it's an Impella, it's a total artificial heart, and there was no pulse. And we said people can live without a pulse. The LVADs, people have got very, very minimal pulse. But what we saw at that time, and the study in the New England Journal showed, continuous flow LVADs have got an increased risk of bleeding. That's probably to do with the von Willebrand's factor. And they also become really edematous. And I remember watching them as I was younger. They survive, but they become edematous. And I think looking at it, it's the microcirculation becomes dysfunctional, the endothelial, the gap junctions open up, because we've evolved to have a pulse. There's a purpose, and that purpose at the microvasculature is important, and it's got an endocrine function. That shear stress is important. So the origin of the pulse, whether it's native or mechanical, I don't know that it matters. We don't know. I mean, we're scratching the surface here. I would imagine a native pulse is better for you than a machine pulse, because most of the things in our bodies, we've been working in LVADs for 30 or 40 years. Allah has been working in the body for 40 million years. So we'll probably have to, it probably works better. Against that, I guess your question is, if we develop a pulse from the machine, do we inhibit the return of the native pulse? I don't think so. I think the action of that pulse, the opening of the aortic valve, the changing of all the different mediators, I went through just some of the pulmonary ones, but there's a huge number. The fact that you return this to normality, I would think, but I've got no evidence, I would think that that would probably open the microvasculature. Well, we know it opens the microvasculature. We know it's better for mitochondrial function, increased ATP, less reactive oxygen species. So it brings us back to a more physiological milieu. And once you have that physiological milieu, then perhaps your native pulse returns. But that's working from first principles, not from data.
Can I follow up question to Emma about this? So is the nutrition support different than from VV ECMO and MVA ECMO, given the lack of pulsatility? Does it have a consequence, this lack of pulsatility, on the digestive system that you may notice, or can you elaborate on that?
Yeah, I think the degree of edema and things that they can get, it definitely impacts our ability to feed. And so if a patient is really edematous, you can assume generally their gut is also going to be impacted. So their motility is reduced overall. And so I do think there is a slight difference. They're harder to feed often in that circumstance. It'll be interesting to see how it all evolves and if that does change things further. But yeah, I think there is a difference.
So what we can do then, Emma, great question. why don't we look at the microcirculation and the mesentery when the next time we go into we'll go into the animal models soon for some other ones, and we'll look at the mesentery and the microcirculation at the mesentery level and get Vin to do the work, because he said all these compliments. We need to stop it. Do a blinded study of what the circulation is like, and we can put a tissue oximetry probe into the gut and see what happens.
No, well, the most interesting thing I took out of all this is the fascination we have with mortality as our primary outcome for all these trials. And it may have slipped your attention, but it didn't slip my attention when Emma presented the trial with looking at how the survivors do. See, all we always think about is like how many people died, and we sort of pay no respect at all in the outcome to the survivorship of our patients. And hopefully there are more survivors than not. And there are probably a lot of signals and treatments that we've given up with over the year because it didn't result in an absolute mortality reduction, but it may very well have changed the survivorship in the group. We haven't looked at it. So a point I would make is that the use of metrics that measure survivorship, I'm very supportive. I think they have a really good place, because surviving ECMO is one thing, being well after surviving ECMO is a complete another thing, and the more we understand that going forward. So I support the move in that direction.
Can I say, I completely agree. The multimodal outcome measure is key to go. Yeah. Very, very expensive though, and very expensive to measure, at least in Canada, because organizing follow-ups in long term. Okay, but definitely I think is the future of clinical trials.